Good afternoon. Thank you for joining this expert webinar. Today, we're going to talk about anaphylaxis, which is the kind of most common, kind of most emergent, life-threatening reaction we think about when we think about allergies and food allergies. So I'll talk a little bit today about kind of the diagnosis of anaphylaxis, the pathophysiology behind it, and the treatment. So we'll start with just a quick poll question. Have you or your loved one ever experienced anaphylaxis? Yes or no? Do you have the results? Yeah. Okay, so it looks like about 64% of people are yes and 36 no. Okay, great. So looks like a lot of you already know or experienced anaphylaxis. So we'll talk a little bit more in detail. So what is anaphylaxis? The international consensus on anaphylaxis has a pretty general definition, and it describes anaphylaxis as a serious, generalized, or systemic allergic or hypersensitivity reaction that can be life-threatening or fatal. It's most often an immunologic reaction to foods, medications, immunotherapy, and insect stings. And of course, in children, it's most often caused by foods, and in adults, it's most often with medications. So anaphylaxis, the lifetime prevalence is currently estimated to be at 0.05 to 2% in the US and about 3% in Europe. There are several studies that show there's an increase in the incidence of anaphylaxis worldwide at about a rate of 1 to 2% increase per year. However, thankfully, the mortality from anaphylaxis is stably low at about 0.3% case fatality risk. And those are usually from late recognition and treatment of anaphylaxis. In patients with food allergies, asthma is known to be associated with more severe reactions and an increased risk for anaphylaxis. And in older patients, things like alcohol use, exercise or stress, menstrual periods, and concurrent medications like NSAIDs may also exacerbate anaphylaxis reactions. So anaphylaxis can present in a wide variety of ways, and there's 3 diagnostic criteria. A patient can be diagnosed with anaphylaxis if they meet any one of the following 3 criteria. The first is an acute onset of illness, usually within minutes to several hours, that involves the skin, mucosa, and either respiratory symptoms such as wheezing, shortness of breath, or low oxygen, or low blood pressure. The second is if the patient has 2 or more of the following systemic symptoms that occur after exposure to a likely antigen. That could be skin mucosal involvement, persistent GI symptoms, respiratory symptoms, or low blood pressure. And finally, if they have low blood pressure after exposure to a known allergen, that could be diagnosis of anaphylaxis as well. So diagnosis of anaphylaxis is clinical. There's no specific lab test to say that person has anaphylaxis. Oftentimes we could test things like tryptase, but those are short-lived and not really available at the point of care. So it's very important to recognize the clinical signs and symptoms, as anaphylaxis needs quick recognition of treatment. And the time course of anaphylaxis is quite unpredictable. Sometimes it could be mild and resolve spontaneously on its own, or it could be severe and rapidly fatal as well. In a minority of patients, about 5% can have a biphasic allergic reaction. So their initial symptoms resolve, and then later on, after typically within 12 hours, they can have a recurrence of symptoms. And this has been reported even up to 72 hours after the initial symptoms have resolved. So what is the kind of pathophysiology behind anaphylaxis? Why do people develop these severe systemic allergic reactions? The most common cause is IgE driven. So when a patient is exposed to allergens, it causes the development of allergen-specific IgE antibodies. These IgE antibodies then bind to the high affinity receptors on basophils and mast cells and other cells in the blood. And when the patient is exposed to the same allergen again in the future, it causes the cross-linking of these IgE receptors and the subsequent activation of mast cells and basophils. And these mast cells and basophils immediately release a lot of chemical mediators, such as histamine, and then also cause creation of or synthesis of more inflammatory mediators as well. And we'll talk a little bit more about that in detail. So this is just a graphic representation of what I described. First, the allergen kind of activates cells in the immune system called helper T cells, which then drives the differentiation of B cells into plasma cells that actually make the IgE antibody. And they bind to these receptors on mast cells and basophils, and subsequent exposures would cause the release of these chemical mediators. So not all anaphylaxis is completely driven by IgE. We know this because IgE levels in the blood alone don't explain an individual susceptibility to anaphylaxis. Some people can have very high levels of IgE, allergen-specific IgE, and have no reactions when exposed to that allergen, while some people can have severe reactions even though they have lower undetectable levels of IgE. Non-IgE mediated triggers of anaphylaxis usually involves the direct activation of mast cells and basophils to release their chemical mediators. And that could be triggered by medications such as antibiotics or opiates, radio contrast media used for CT scanners, could be physiologic triggers like cold weather. There's also some studies that show there's an IgG mediated anaphylaxis pathway, and that's been identified in mouse models, but not yet demonstrated in humans. So regardless of the mechanism, the end result is kind of the release of large amounts of chemical mediators from mast cells and basophils. They're released into the tissues and blood very quickly during anaphylaxis, kind of causing the signs and symptoms that we see. The most well-studied and well-known of these chemical mediators is, of course, histamine. And histamine causes skin flushing, itching, GI symptoms such as abdominal pain and nausea, cough, runny nose, the airway obstruction, low blood pressure, high heart rate, etc. So it really affects all the body systems that we see. And it does this mostly by increased vessel permeability, which causes swelling of the airways, tissues, and gut, leading to those symptoms. There's some other chemical mediators that are not as well studied that have been shown to play a part in anaphylaxis, such as the platelet activating factor, which can induce wheel and flare reactions and may act synergistically with histamine. Leukotrienes can also cause hives and flushing, and is a very strong airway constrictor agent. And other factors like tryptase, prostaglandins, and other cytokines also play a role as well. So this is just a graph kind of illustrating the different effects of the chemical mediators in different body systems. So how do we treat anaphylaxis? And most of you already know this, but the first line treatment, the most effective treatment, is injectable epinephrine. And epinephrine is a very safe and effective treatment for anaphylaxis because it really counteracts all the pathophysiology of anaphylaxis that we had described. So epinephrine activates receptors on cells. It activates alpha-1 receptors, which causes vasoconstriction, and that prevents and kind of diminishes all the swelling that we see in the tissues and increases blood pressure. The beta-1 receptors increases heart rate and increases heart contractility to also raise blood pressure. And the beta-2 receptors can dilate airways and may potentially block further release of chemical mediators. So for epinephrine, the most common one we think about is an EpiPen. But now there's actually a wide variety of brands and brand names and generics that we can choose from. And you can pick one that's covered by your insurance. Important things to know about epinephrine is that it usually comes in a pack of 2, and you should always carry 2 epinephrine auto-injectors with you at all times. So if you suspect anaphylaxis, give dose early. And if you don't see improvement of symptoms within 10, 15 minutes, you should give the second epinephrine injection. Important to make sure that the EpiPen is not expired. So always check the expiration date. Epinephrine should be kept at room temperature. So avoid, refrigerating it or keeping it in a hot car in the summer. They usually come with a trainer. So practice with a trainer, make sure you know how to use your EpiPen when the time comes. And it should be injected intramuscularly in the outer thigh. And it can be given through clothing or on bare skin as well. And you should always call 911 after giving epi so they can be assessed in the emergency room. So all the other therapies for anaphylaxis are kind of adjunctive and second line and not a substitute for epinephrine. But other things you could give, patients with anaphylaxis should be in a laying position and given oral or IV fluids if in the emergency room. Things like antihistamines can help with skin and GI symptoms as well. And oftentimes in the emergency room, people get steroids, which some think may prevent biphasic reactions, but do not prevent the severe effects of anaphylaxis. And there are some clinical trials that show that the anti-IgE antibody, omalizumab or Xolair, when it's given during food or other immunotherapies, can decrease the risk of participants developing anaphylaxis. However, it is not a treatment for anaphylaxis. So finally, if you have experienced anaphylaxis and you're treated and this is your first time experiencing anaphylaxis, it's very important to figure out what the allergen is and what triggered the reaction. The most important part about this is getting a good detailed history about what exposures may have happened prior to the reaction and kind of order of events that happened. Then your allergist could perform skin prick testing, measure IgE in the serum, etc. But this is all kind of concurrent with the clinical history. So a positive skin test or IgE test may only reflect sensitization to the allergen, not a true allergy. So that has to be taken in context with the clinical history as well. Things like oral food challenges may be needed to exclude or confirm a certain allergen if needed. And in cases where no triggers can be identified, it's important to consider a different diagnosis or hidden exposures. Sometimes people have mast cell disorders or idiopathic anaphylaxis in a portion of the patients as well. So that concludes my talk for today. Please visit our YouTube channel online. We do post our Ask the Expert webinars on YouTube. And we have our clinical trial website as well as our registry and our contact information as well. So thank you so much for joining.
We're opening up the floor to questions. Can one have anaphylaxis from food with only hypertension and no skin or respiratory symptoms? If so, why does that happen?
Yes, I think so. One diagnostic criteria is, if you have an exposure to a known allergen and low blood pressure, that matches, that's a diagnostic criteria for anaphylaxis. So you don't necessarily need all the other symptoms. And like I said, the presentation can be variable. So sometimes people can have different presentations, and it just depends on the way the body responds to the allergen, and they could develop different symptoms in different sequences as well. Any other questions? And so how do we confirm a diagnosis of anaphylaxis? I think, like I said, it's usually clinical diagnosis. So based on those clinical criteria, kind of reviewing the patient's symptoms and progression of events and their allergy history, that's usually enough to confirm a diagnosis of anaphylaxis. The cost of epinephrine is rising and effectiveness is shown beyond date. Oh. Topics and use beyond expiration date. So I think we generally don't recommend using expired epinephrine. So I know a couple years ago, there was a big controversy about the drastic, expense and increase in cost of EpiPens. Thankfully, that has changed in recent years due to more generic brands appearing, due to more options. So definitely, I think if you have coverage with your insurance, epinephrine pens are much more affordable nowadays. And in general, we don't recommend using expired medications just because we don't know the safety and efficacy of medications beyond the expiration date. In general, if that's the only one thing you have available, it's definitely, still use it, but that's why it's important to make sure your EpiPens are not expired and kind of get renewed prescriptions from your allergist if it is. And the next question, can oral immunotherapy potentially treat all kinds of food allergies? So far, I'm only aware of one for peanut allergy. Are there others? Yes, so oral immunotherapy can be used to treat all kinds of different food allergies. For example, we have several clinical trials going on at our center that involves multi-food allergies, to milk or eggs or nuts. So it definitely can be used to treat all kinds of food allergies. How does mast cell anaphylaxis differentiate from an IG anaphylaxis? So my understanding is that for IG anaphylaxis, I can explain the pathophysiology is from the production of these allergen-specific IgEs because of the immune response. While mast cell anaphylaxis, it's a mast cell disorder. So mast cells get directly triggered to release histamines and other chemical mediators that trigger anaphylaxis. So it doesn't have that IgE component. And, Katie and Jathy, feel free to add anything if needed. Any other questions? If no questions, then we can end today's talk early. Like I said, thank you all so much for being here, and hope to see you next month.
Thank you, everybody. This presentation will be on our YouTube channel. Check out tomorrow. Thank you.